Good morning, student. Yesterday we have discussed about the basics of jugular venous pressure. Let us revise what we have learned yesterday. We have learned that though we can see the JVP even in external jugular vein, but preferably we see the JVP in internal jugular vein. We have also discussed about the different waves in JVP. In the JVP, there is a first positive wave, that is A wave, then there is C wave, then there is a X descent, then there is a V wave, then there is a Y descent. This is Y descent. So the first positive deflection is A wave, second is C wave, and this is the X wave, and this is V wave, and this is the Y wave. So A wave is formed because of the atrial contraction. When atrial contracts, it increases the intra-atrial pressure, and that pressure will disseminate to the internal jugular vein. That's why we see the A wave. C wave is because of the ventricular contraction. When the ventricle is contracting, it will exert the pressure in the tricuspid valve, so that tricuspid valve bulges towards the right atrium, and that increases the right atrial pressure. So that's why we see the small positive deflection. X is because of the atrial relaxation. V is because of the atrial filling. Once the atrial get relaxed, atrium should be filled by the blood that is drained by the vena cava. When the blood is coming towards the atrium, then definitely it increases the intra-atrial pressure. That's why you see the V wave. Now atrial is filled. Once the atrial get filled, then the tricuspid valves open, and when the tricuspid valves open, the blood from the atrium goes towards the right ventricles. That drops the right atrial pressure. That's why you see the negative deflection. That is what we call the Y wave. So in the JVP, we see three positive deflection, that is A, C and V are the positive deflection, and X and Y are the negative deflection. So today we learn what are the abnormalities of these waves. Okay, so we'll go one by one. So first we'll learn about the abnormalities of A wave. A wave. So what is the mechanism of A wave formation? It is because of the atrial contraction. Because of the atrial contraction. Because of the atrial contraction. This is superior vena cava, this is inferior vena cava, this is right brachiocephalic, this is left brachiocephalic, this is internal jugular, this is external jugular, then the subclavian vein. So right atrium. So the mechanism of A wave formation is the right atrial contraction. Okay, so if there is some problem in the tricuspid valve, let's suppose there is the tricuspid valve is stenosed, mean that it is not opening properly, it is stenosed. Okay, when tricuspid valve is stenosed and when the right atrium is contracting, it has to contract with more force. When right atrium is contracting with more force, it will increase the more pressure over the right atrium here. So one condition in case of tricuspid stenosis, the right atrium has to give more force against the tricuspid valve. Similarly, let's suppose tricuspid valve is normal in another scenario, but there is increase in the right ventricular RV pressure, like there is right ventricular hypertrophy or because of the pulmonary artery hypertension. So if there is an increase in right ventricular pressure because of right ventricular hypertrophy, or because of fibrosis of the right ventricle, or because of the pulmonary artery hypertension, then definitely the right atrium has to contract more forcibly. So when right atrium is contracting more forcibly against the right ventricle, then definitely there will be the more pressure in the right atrium, and if there is more pressure in the right atrium, then there will be the more pressure in the jugular veins. So that's why in a condition where there is increase in right ventricular pressure, like in case of cor pulmonale, pulmonary artery hypertension or restrictive cardiomyopathy, we see the A wave amplitude is high. A wave amplitude is high, and that particular A wave is called the giant A wave. Giant A wave. So giant A wave. So you will see the giant A wave if there is a resistance against the right atrial contractions. Resistance can be given by the tricuspid valve stenosis or tricuspid valve myxoma or right ventricular hypertrophy, the etiology of which may be different. So your teacher can ask you, so what is the typical wave you see in a case of cor pulmonale? Then one typical wave you will see in a case of cor pulmonale is a prominent A wave. Okay, so that's why you have to answer like that. So what are the causes of giant wave? The causes of giant wave are tricuspid stenosis or right ventricular hypertrophy, pulmonary artery hypertension. These are the cause of the giant A wave. Okay, second is sometimes there is one condition called the complete heart block. Complete heart block, where there is a atrium and ventricle is contracting in different time. So atrium and ventricle contracting separately. So now ventricle contract, then like when it is contracting, sometimes what happens, so there can be a time where the tricuspid valves are closed. Okay, and atrium is contracting. That can occur in case of AV dissociation or complete heart block. When the atrium is contracting against the closed tricuspid valve, then there will be again more pressure in the right atrium, and that can be seen in case of in internal jugular vein. So that A wave is very high. A wave is very high. That is called the Cannon A wave. Cannon A wave. So you will see the Cannon A wave in a case of AV dissociation or complete heart block. What is the mechanism? Because right atrium is contracting against the closed tricuspid valve. When you are contracting against the closed tricuspid valve, you have to give more force. So there will be more increase in the right atrial pressure, and that right atrial pressure can be seen in the internal jugular vein. So it may be too high in a patient with complete heart block. That is what we call the Cannon A wave. So I think you people have understood about the giant A wave and the Cannon A wave. So can you tell me one conditions when right atrium is not contracting at all? Just memorize or think. Yes, so one condition where the right atrium is not contracting is atrial fibrillation. You know, as the definition of the fibrillation, so there is no contraction of the atrium in fibrillation. There is just only fibrillary waves is there. There is no effective contraction of the right atrium. When the right atrium is not contracting effectively, then there will be no A wave. There is no A wave in JVP. So what is the cause of absent A wave in JVP? You have to tell atrial fibrillation. Why? Because in atrial fibrillation there is no effective atrial contraction. That's why if there is no effective atrial contraction, then we can't see the A wave. So these are the abnormalities of A wave. In one scenario there is absent A wave. In another scenario there is a very high A wave, and I think you people understood the mechanism. Okay, similarly, after A wave, let's think about the C wave. This is A wave. This is C wave, this is X, this is V, and this. Let's think about this wave. So what is the mechanism of the C wave? What is the mechanism of the C wave? The mechanism of C wave is because of the ventricular contraction. Because of ventricular contraction, it will bulge the tricuspid valve. It will bulge the tricuspid valve. So it will bulge the tricuspid valve. But if there is a condition called, if there is a TR, it is a pliable valve. Tricuspid is TR. In case of TR, when the ventricle is contracting, all the blood from the some of the blood from the ventricle will goes to the right atrium. If the blood from right ventricle is going towards the right atrium, then definitely it will exert more pressure to the right atrium. In case of TR, that's why in a patient with TR, you will see the more there is increase in amplitude of the C wave, So when there is a severe TR, sometimes what you will see the C wave is so like there is increase in amplitude and it is more broader, so that it can fuse even with the V wave. Like this is called the CV wave. So this is the severe TR. In case of mild TR. So in case of mild TR, you can see the prominent C wave. There is increase in amplitude and there is increase in the time of the C wave. But in case of severe TR, even C and V wave will merge. That is the abnormalities of C wave that you will see in a patient. Why we see the prominent C wave? Because in a case of TR, some of the blood is going towards the right atrium, and that will increase the right atrial pressure. When there is increase the right atrial pressure, then definitely C wave amplitude will be more. C wave amplitude will be more. That's why you will see the CV wave in a patient with TR. So then we have to learn about the X descent and the Y descent. X descent and the Y descent is very important. So what is the mechanism of X descent? What is the mechanism of X descent? X descent. What? The mechanism of X descent is because of the atrial relaxation. Is because of the atrial relaxation. Okay, and the mechanism of the Y descent is because of the flow of the blood from atrium to ventricle. So to differentiate between the two conditions called constrictive pericarditis and cardiac tamponade, you have to know about the X descent and the Y descent. For that, you need to know what happens in a patient with cardiac tamponade and the constrictive pericarditis. Let's suppose this is cardiac tamponade. This is cardiac tamponade. And this is constrictive pericarditis. Constrictive pericarditis. In case of cardiac tamponade, what happens? It is exerting the pressure to the heart throughout all phase of the diastole. Throughout diastole, you have to remember that diastole, throughout diastole. So in case of cardiac tamponade, it is exerting the pressure, it is exerting the positive pressure throughout the diastole, so that heart cannot relax properly, because at the time of relaxation, at the time of the diastole, if there is the positive pressure coming from the pericardium, then it cannot relax properly. So that is the main fundamentals of the cardiac tamponade. Whereas in case of constrictive pericarditis, it impaired the flow only in late diastole, only in late diastole. So it will exert the pressure only in late diastolic phase. It will not impair the flow of the blood from atrium to the ventricle in early diastole. It will exert the pressure only in the last part of the ventricular relaxation. That is what you need to remember. So again, in case of cardiac tamponade, it will exert the pressure throughout the diastole, whereas in case of constrictive pericarditis, it will exert the pressure, positive pressure, only in late diastolic phase. That is what you need to remember. Then what about the wide descent? The wide descent is because after the tricuspid valve open, blood flows from atrium to the ventricle. Then what happens in case of the cardiac tamponade? Do you think blood can flow from right atrium to the ventricle in a case of cardiac tamponade? Blood cannot flow from right atrium to ventricle properly, because cardiac tamponade is exerting the pressure from outside to the ventricles. It cannot come out. That's why if it cannot come out, then it cannot decreases the pressure of the right atrium. If it cannot decreases the pressure of right atrium, then you won't see the wide descent. In case of there will be no wide descent in cardiac tamponade. There is only X descent is there, but there is no Y descent in cardiac tamponade. Why there is no Y descent? Because cardiac tamponade is exerting the positive pressure throughout the diastole. In case of the constrictive pericarditis, it will exert only in the late diastolic phase. So there will be the A wave, this is C wave, this is V wave, but there is Y wave or not? There will be Y wave, because blood will flow from right atrium to the right ventricle. Only in the early diastole phase. So blood will come, but blood will come to the diastole, but it will restrict the flow of blood from the late part. So again it became the positive waves, because in the last part of the diastole the blood cannot flow. That's why the right atrial will become positive, and you will see the prominent Y descent in case of the constrictive pericarditis. That is the difference between the cardiac tamponade and the constrictive pericarditis. In constrictive pericarditis, you will see the both X and prominent Y descent, prominent and sharp Y descent. Whereas in case of cardiac tamponade, you will see the X descent but no Y descent. I think you people understood the mechanism of X descent and the Y descent. Then I think this is the last topic for today's presentation. That is Kussmaul sign. I forgot one thing. Okay, the prominent Y descent in a patient with constrictive pericarditis is also called the Friedreich's sign. Okay, the prominent Y descent in a patient with the constrictive pericarditis is also called the Friedreich's sign. Okay, that is what you need to remember. Then Kussmaul sign. So yesterday we have discussed. So what happens? What is the effect of respiration over JBP? When we are inspiring, taking deep breath, it ultimately decreases the intrapericardial pressure. Ultimately decreases the intrapericardial pressure, because first it will decrease the intrapleural pressure, then intrapericardial pressure when we are inspiring. When it drops the intrapericardial pressure, then it will shock the blood from vena cava, and it will drop the pulsation at the internal jugular vein in case of Kussmaul sign by more than 3 centimeter. This is a normal phenomena. But what is Kussmaul sign? So there are some conditions. If there is a pathology like here, if there is a pathology like cardiac tamponade or constrictive pericarditis, okay, or sometimes even in case of the severe right sided heart failure, what happens? When you are inspiring, the pressure in the right ventricle is so much that it cannot accommodate the extra amount of blood. It cannot accommodate extra amount of the blood. Extra amount of blood from inferior vena cava and superior vena cava. When you are inspiring, the pressure in the right ventricle is so much that it cannot accommodate the blood coming from the vena cava. When it cannot accommodate the blood coming from the vena cava, right ventricle, then definitely it will increase the pressure in the right atrium and there will be no drop in the jugular venous pulsation. This is called Kussmaul sign positive. Okay, so what are the causes of Kussmaul sign positive? The constrictive pericarditis, or sometimes in cardiac tamponade or right RVMI or right sided heart failure, you can see the Kussmaul sign positive. Why? Because during inspiration normally it can accommodate the blood, but in these conditions it cannot accommodate the extra amount of blood in the ventricles. That's why it will increase the pressure in the right ventricle as well as right atrium, and that can be seen in the JBP. So this is the mechanism of Kussmaul sign. So today we have learned about some of the abnormalities in the JBP. So A wave, the prominent A wave is seen in case of the tricuspid stenosis or right ventricular hypertrophy, or conditions where there is increase in right ventricular pressure, whereas Cannon A wave is seen in case of AB dissociation. As the A wave, because of the atrial contraction, we are not going to see the A wave in a patient with atrial fibrillation. We see the prominent C wave in a patient with TR, and there will be no wide descent in a patient with cardiac tamponade. Absent of wide descent differentiate the cardiac tamponade from the constrictive pericarditis physiology. Okay, and we have also discussed about the Kussmaul sign. So I think this in the today's presentation. If you have any comments and any queries, you can write in the comment section. Thank you so much for your kind attention.